Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. I'm Dr. Louise Kugler, a specialist GP, and today I welcome to the podcast Dr. Giresh Kanji to discuss fibromyalgia and the pain response. Giresh is a musculoskeletal pain specialist and researcher. He explored the sensory amplification of pain in his PhD, including the role of the human stress response. Giresh is an honorary associate professor at Auckland University, the chairperson of the New Zealand Pain Foundation, and the editor of the Australasian Musculoskeletal Medicine. He is the author of a number of books, including Fix Your Back, Fix Your Neck Pain, Headache and Migraine, and the 2019 New Zealand bestseller about insomnia, anxiety and depression, Brain Connections, How to Sleep Better, Worry Less, and Feel Happier. Kia ora, Giresh, and welcome back to the podcast.
Thank you, Louise, for having me.
So today we're talking about fibromyalgia. So can we just start with how we would make this diagnosis?
Well, I think the most important thing to understand for people is that fibromyalgia is not really a diagnosis with a gold standard test. It's not like when we diagnose low iron, we do a blood test and the level of our iron can tell us we've got iron deficiency. Same thing for thyroid disorders. We take a blood test, we find out if the thyroid gland is underactive or overactive. With fibromyalgia, it's a collection of symptoms. We best termed a syndrome. And the collection of symptoms includes widespread pain, poor sleep, fatigue, brain fog, and sometimes depression. A sensitivity to light, sound, touch, and smell is also described. And there's generalized tenderness throughout the muscles of the body, which is how the syndrome is diagnosed as well. And in 1990, a group of rheumatologists sat around a table and they were discussing, mainly women who were arriving in their practices who had pain everywhere, poor sleep, and the symptoms I described above, and there was no real cause for it. So that's where the term fibromyalgia was coined back in 1990 by a group of rheumatologists.
So how common is fibromyalgia?
It's said to be about 2 to 4% of the population, and mostly women. Twice as many women as men are diagnosed with fibromyalgia.
So I wonder if we can chat a little bit about the pathophysiology and what's happening in the body to create this clinical picture of pain and tenderness.
Well, during my PhD, I studied the stress response. Basically, it was about stress and pain. And fibromyalgia is best thought of as a pain condition which is complicated by the stress response. And it's best if we separate the symptoms to really understand it. In many patients, I've seen they often have spinal pain arising from the neck and lower back, which has been present for many years, and their scans will show us some pathology such as narrow discs or facet joint changes, which will give them back or neck pain or both. Now, pain produces a stress response, and the stress then leads to symptoms. And as we know, the symptoms of stress are poor sleep, and the poor sleep will lead to secondary fatigue. We have anxiety, depression, and brain fog. So lots of people who experience stress from any condition, whether it be bereavement or otherwise, will also experience these symptoms and brain fog. The stress chemicals are known to attach to the hippocampus and shrink this part of the brain, which is important in memory, and this can lead to poor concentration in memory, which we call brain fog. Now, a patient in her 70s presented with a diagnosis of fibromyalgia recently, in fact, last week. And over 30 years ago, she was diagnosed with fibromyalgia. She had pain throughout her body, she had poor sleep, she was tired all the time, and her memory and concentration wasn't flash. So what we did, we concentrated on her sleep, and her fatigue improved. And then we did some scans, and we did a scan of her neck and her lower back. And what we found was discs that were quite narrow in both the neck and lower back. And I suspect that these changes have been there for over 3 decades when her diagnosis was made. However, there were no scans, so there was no understanding of the underlying pain condition that basically led to this diagnosis of fibromyalgia. Now, to understand fibromyalgia, we need to look at the factors that influence our pain experience, including musculoskeletal pain, which is biomechanically mediated, the role of loading, migraine genetics, and the autonomic nervous system, which is our stress nervous system.
So, Giresh, you've mentioned the pain experience. I wonder if you can talk us through what you mean by this.
Okay, so we've got a few types of pain. Firstly, we've got musculoskeletal pain, and we have bones and washers, and there is a washer between every two bones in the body. Now, what often happens is when the washer gets damaged, pressure creates pain, or loading creates pain. And the most simple example of this is knee pain. I've got a little bit of arthritis in my knee, and if I run, it hurts, but if I sit down, there's no pain. Now, even if I walk, I don't get a lot of pain. So loading creates pain, and that's how we'd sort of think about musculoskeletal pain. Now, if we thought about the back, if I've got a disc problem, if I do a lot of lifting or bending, I'm loading my bones because the disc is narrowed, and that will lead to electricity, which travels to the brain, giving rise to the pain experience. Now, one of the important things is everyone experiences pain different. So if two people have arthritis of the knee, one may not feel it at all, and one may feel lots of pain. Why is this? This is a very important question. One of the main considerations is migraine genetics. People with migraine have electrical channels in their brain and the sensory cortex, which open up quicker and produce more action potentials or electricity. And so what happens is their channels are actually genetically different, and they've been typed for many types of migraine as well. They have different ATPases, different calcium channels sometimes. They're structurally different. And this is why people with migraine are sensitive to all sensations, including light, sound, pain, touch, and smell. It's like when the electricity goes from your knee to your brain, if you have migraine, the electricity doubles and triples. So it gives you a higher pain experience. People with migraine in the studies are 6 times more likely to be diagnosed with fibromyalgia. They are best thought of as people who amplify sensations, including pain. Now, the other major factor that increases our pain experience is the stress system. When we experience stress, electricity is released in our body and attaches to parts of our brain. When it attaches to the part of our brain that subserves pain, we have increased electricity and experience increased pain. So stress can directly increase our pain experience. Now, as we know that because pain produces stress chemicals in turn go around and create more pain. Stress chemicals also reduce our ability to sleep and therefore give rise to fatigue. So sleep is a big target when I deal with people with chronic pain. It's one of my key areas to target is their sleep.
So, Giresh, pain cycles, it feels like there are several pain cycles in motion with chronic pain, such as the pain stress cycle, the stress poor sleep cycle, and poor sleep fatigue cycle. I wonder if we can talk about these for a moment, perhaps starting with the pain stress cycle.
Now, this is right, Louise. What actually happens is that there are vicious cycles set up over time, and these vicious cycles tend to create symptoms for the longer term and make them much harder to reduce. So with the pain stress cycle, pain produces stress chemicals, and stress chemicals in turn go around to the brain and produce more electricity, creating more pain. And this in turn creates more pain. So we've got pain producing stress and stress producing pain, and this goes round and round.
And what about stress causing poor sleep?
Well, as we know, stress increases electricity in our parts of the brain that are important in sleep. And the more electricity we have in these parts of the brain, the more awake we are, the less electricity, the more we sleep well. So stress produces electricity and makes us stay awake. And when we sleep, a very important thing happens. Our stress system almost goes into negative stress when we sleep. So every night we don't sleep, we don't get that stress reset. And then we wake up during the morning, and what's happened is our stress symptoms are elevated straight away if we do not have a good night's sleep.
So, Giresh, the poor sleep fatigue cycle, if we're not sleeping well, there are lots of hormones released, aren't there? So what are the hormones at play here?
This is a fascinating topic, and while we sleep, we produce growth hormone, estrogen, progesterone, testosterone, prolactin, and cortisol. And all of these give us vitality. Cortisol in particular gives us energy and is highest in the morning when we wake and almost zero at 9 to 10 p.m., which causes sleepiness. And if we don't sleep, we do not get the morning spike of cortisol and other hormones which give us vitality.
Poor sleep, particularly, often compounds and we become stressed and anxious and depressed. So there's a cycle that goes there too.
So when the stress chemicals attach to our brain, they increase electricity throughout the brain. And some centers like the amygdala are responsible for panic attacks, anxiety, and anger irritability. Other centers like the reticular formation are responsible for sleep. And then what happens is the system is designed for the tiger. So we see the tiger, the stress chemicals go up. We want to be awake, anxious, and aggressive. What happens if the stress chemicals carry on for too long is the second wave of symptoms is often things like depression. And so these often come later down the track.
Giresh, what about people living with chronic pain? I wonder if they're more often diagnosed with fibromyalgia because of the cycles that we've just discussed.
Absolutely. People with chronic pain are diagnosed with fibromyalgia. Sort of 20 to 30% of patients with rheumatological conditions such as rheumatoid arthritis qualify for a diagnosis of fibromyalgia. The significant pain in rheumatological conditions sets off the pain, stress, poor sleep cycles.
Have there been any studies that have sort of looked into this?
There's been a couple of studies, and one study of 102 patients with whiplash compared patients with whiplash and 59 patients with leg fractures. And they were reviewed in an outpatient clinic 12 months after the accident occurred. 20% of those with whiplash developed fibromyalgia, and only 2% of those with leg fractures. Now, this makes a bit of sense because leg fractures can be treated often with a plaster cast, and most of them will do very well. Neck pain, on the other hand, we don't have great treatments that leads to sort of such a good response, and hence people with neck pain are more likely to develop long-term pain and perhaps a diagnosis of fibromyalgia. There has been another study, however, which studied a couple of hundred people and found that there was no increased risk of fibromyalgia in that study from people with whiplash. There was a difference between the two studies, however. One study looked at patients at 12 months, the first study, and if people presented to an outpatient setting at 12 months, they probably still had symptoms. The second study, which found no increase in fibromyalgia, followed patients right from day one when they had their accident. And what would happen is after 12 months, probably about 80 to 90% of patients would actually improve in 12 months. And so they wouldn't have the chronic pain. Hence, they might not go on to develop fibromyalgia.
Fascinating. I wonder if we can move on now to talk about management of fibromyalgia and how we best approach the patient. What's your strategy?
I think we need to break it into two parts. One is we need to manage underlying musculoskeletal pain. And, this often, if patients experience spinal pain, then obtaining an investigation, an X-ray or a scan, just to see what the discs, facet joints are doing, can help. And they can help in two ways. One is the patient can understand that there's a potential pain generator. And if we unload that area, we may be able to improve the spinal pain through activity modification, postural adjustments to reduce loading, and that may help underlying spinal symptoms. Now, if we can reduce spinal pain, then hopefully we reduce the activity of the stress system because the pain is less and the stress response reduces. I think activities modification is very important. I often say if it hurts, don't do it. However, you need to do something else. We all need to move to some degree. And however, if we're experiencing increased pain on moving, like with my knee, I don't run because it causes pain. And I instead go down to the swimming pool. I might walk up and down the water to waist height. I may swim. I may do cycling, and those things won't load my knee. So it's important to move, but important to change the activity so it doesn't hurt. Now, the other part of the equation is to reduce the stress symptoms. So we need to reduce the activity of the stress system. And that may help people sleep. And there are other symptoms which may help fatigue, brain fog, and also anxiety and depression. So one of the key target areas is sleep. Improving sleep can help the activity of the stress nervous system, improving all the other symptoms. Now, both habits and tablets are required. I think we need to use all the tools in the toolbox for people who have had chronic symptoms. And although some people shy away from tablets, I'll often encourage them that if they've been sleeping poorly for a long time, tablets can be very useful. Now, when I prescribe tablets for sleep, I prescribe common sedatives such as amitriptyline, zopiclone, quetiapine, promethazine, melatonin. It doesn't matter which sedative. I prescribe 3 tablets and I ask the patient to alternate them. So take tablet A on day 1, tablet B on day 2, and tablet C on day 3, and then go back to tablet A in the smallest dose possible. This reduces the key problem of tolerance, where a tablet no longer works because you've taken it too long and your brain's got used to it. So that's a really useful way to use sedating medications.
Giresh, not everyone, and myself included, would want to take a tablet. So are there any other options?
Absolutely. There are 5 habits that reduce the activity of the stress system, including heat in the form of sauna, spa, bath, and 20 minutes, 3 or 4 days a week is excellent. Heat is the number 1 habit in my experience of reducing the stress nervous system. And studies have shown people attending the sauna for 15 minutes, 5 days a week, and 4 weeks, in studies in Japan, their stress system activity has reduced when they've measured it. Now, quite often, not everyone will tolerate the sauna. And so if you don't tolerate the sauna, it's not for you. And I personally go to the sauna 4 days a week for around 15 to 20 minutes to maintain my health and in particular my sleep.
Does it matter what kind of sauna you go to?
No, it doesn't. Any heat is good. And that's why you can do the hot bath, the spa, infrared saunas, or the steam saunas. Anything where you derive heat is good. Now, the other really interesting fact that even today, a patient told me that they'd gone overseas to the tropics and their pain had just about obliterated. It really reduced by about 60, 70%. Some patients, if you're lucky enough to move to a warm climate, that would also help reduce your pain levels significantly.
So, Giresh, you mentioned 5 habits for restoring sleep. So we've talked about heat and we've talked about tablets. What were the other ones?
Meditation breathing is an extremely useful thing to do. And the way it works is that when we stretch our lungs, we actually increase our parasympathetic, which is our relaxation nervous system activity. And when we breathe out slowly, we reduce our sympathetic nervous system activity, which is our stress system. So it's absolutely the ideal way to reduce the activity of your stress brain. What I get people to do is lie on their bed. That way there's no pressure on their joints and no pressure on their spines. Put their hands on their tummy, breathe in for 5 seconds, hold it for 5, and breathe out for 5. And they don't have to chant anything. They can just count to 5. That's enough. And it doesn't matter, even if thoughts come racing into your head, it actually doesn't matter, because it's the stretching of your lungs that is actually the key aspect of this meditation breathing exercise. I started doing this around 5 years ago when I was writing the Brain Connections book, and I found out that it was very useful. And quite often I put my cell phone on sort of a timer, and often I'd put on 10 minutes. And sometimes you want to put on 10 minutes, then do another 10 and another 10 because you'll fall asleep.
Mm-hmm.
So that's a real problem. And you want to try and get up between 20 and 40 minutes a day would be a really good dose. And I used to find when I first started doing this, it would take me about 20 minutes before my brain went completely blank. And it's quite a blissful feeling. This is the meditation feeling that people will describe. And after practicing this for a year or so, it would happen within a few minutes, actually, of lying down and doing the meditation breathing. Now, one of the things I get people to do also is if they can't go to the swimming pool, sauna, spa, or use a hot bath because of water, then an electric blanket is useful. And they can do the meditation breathing while laying in the bed with the electric blanket on high. That will give them both heat and the benefit of the breathing, and it's very cost effective.
So, Giresh, thinking now about the other habits. So, we talked briefly about exercise and making sure that the exercise didn't exacerbate pain. Are there any exercises that are better than others when trying to reduce pain and manage symptoms of fibromyalgia?
One of the problems with exercise is that people are tired. And if you have a lot of fatigue, it's going to limit your ability to exercise. And the other thing is that people will become exhausted, and that exhaustion's not much good too. So I think, firstly, if it hurts, don't do it, and change to something else. And I find, as I was saying before, walking up and down the swimming pool with water to waist height or somewhere is the one exercise that just about everyone can do, which doesn't hurt. So, and you can do it for 15, 20 minutes. I think probably for people with fibromyalgia, I tend to get them to start with using heat if they can tolerate it. And if they can't tolerate heat or have access to sauna, spas, baths, then I'll get them to do the breathing meditation exercise. And quite often, after a few months of the breathing exercise, sometimes with an electric blanket, they feel a lot more relaxed. And if they're then sleeping better, then I say slowly pick up the exercise, maybe in 6 weeks, 8 weeks, maybe go for a walk or do something gentle to start with. That way they can start exercising, down the track once they're sleeping well. I think that works much better than rushing into an exercise program, especially a very vigorous one, because that exhaustion will not help. The other habits, Tai Chi and yoga, also are proven to reduce the activity of the stress system. And both of these incorporate deep breathing, which I suspect is one of the major parts of how they work. And for those habits, 45 minutes, 4 days a week is a good dose.
Thank you, Giresh. So these people are in pain and are often taking multiple medications, including analgesias, pain-modifying tablets, and sometimes even medicinal cannabis. So I wonder if we can just touch on all of these things for a minute and how you see them fitting in to the management.
The biggest help that I've seen in patients is to ensure they sleep. So I think alternating sedatives is an excellent tool. Medicinal cannabis represents another tool which mostly helps people sleep. Now, I've prescribed this for a couple of hundred people over the last 3 or 4 years now, and mostly 99% of them continue it because it helps them sleep. It's not really going to help pain a significant amount for the majority of people with chronic pain, but it does seem to have sedative effects. And there have been 2 studies come out in the last 12 months, randomized control trials, which show that medicinal cannabis with THC and CBD are helpful for sleep. So it's another option for people for sleep, and they may not want to take the medicines, but they may be happy taking medicinal cannabis because it's a natural plant-based product.
And do we have to worry about addiction with that?
Generally speaking, not really, because we're only taking it at night and it's taken in quite a small dose. So I think in a way, if patients sleep well and it's prescribed, we don't really need to worry about addiction for them.
And what about more traditional forms of analgesia?
They don't tend to help a lot. There's the paracetamols, non-steroidal anti-inflammatories, codeine, tramadol. They tend to have, especially codeine, tramadol, tend to have tolerance. And many patients with fibromyalgia are often quite sensitive to medications too. So I think they can be useful, and I think probably more useful in exacerbations. So if their pain is, 5 or 6 or under, then maybe using them when they have an exacerbation of pain now and then would be better because they're more likely to stay effective.
Tell us about pain modification tablets, things like pregabalin and gabapentin.
Yeah. So they work by reducing action potentials in our brain. So that's where they generally work. And I think there's 3 medicines that have been approved by the FDA in the US: duloxetine, milnacipran, and pregabalin. And I think with tablets, it's trial and error. Some people respond, some people get side effects, and some people don't respond at all. So really going through some of these pregabalin and gabapentin and duloxetine. I think it's a matter of cycling through them and seeing if it makes a difference and trialing them one at a time, and then stopping them if they make no difference, or keeping them going while they incorporate the habits and tablets. Hopefully in the future they may not need them.
Fantastic. Well, thank you for your time again today, Giresh. To conclude our podcast, any final thoughts?
In summary, fibromyalgia is best thought of as a pain condition exacerbated by the stress response. And the best management is to address the pain, looking for musculoskeletal sources so these can be addressed, and then also improving the activity of the stress system with habits and tablets. Now, I've seen hundreds of patients over the past few decades diagnosed with fibromyalgia who have spinal pain and joint pain generators. And quite often they haven't been diagnosed, which makes it much more difficult to manage them.
Fantastic. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, please log them. They are eligible. And you'll find a list of resources used in this podcast on our website, goodfellowunit.org. Thanks for listening.